next episode of SRB Surgery Insights. And today we have our beloved SRB sir with us. Today's session is going to be on the examination of hernia. So, for our undergraduate classes, as we know, the most important case that we see, we always get in exams, and we should be very proficient with because of our clinical practice also, is a hernia. So all of us should be very well versed with the examination of hernia, and that is one place where you cannot expect to have any mistakes in the exam. You should be very perfect and thorough with it. Sir has been practicing and teaching about this for so many decades, and he's extremely good at this. So this is going to be a very useful session for us, and we hopefully will get to learn all the small intricacies of hernia examination. And so we will also touch upon the basics of management and what questions can be asked in exam. And let's enjoy the session with sir. On to you, sir.
Thank you, Rajit, for kind introduction. Dear students, thank you very much for joining. We had earlier a few sessions. Today we are going to discuss, like that Rajat has rightly told, it's a very important thing, which examination of hernia for the exam point and surgically very common condition. In theory also it is important. Clinical always kept as a long case. In oxy they may keep short cases, viva. Everywhere it is very crucial. Operative surgery also you should know certain basic thing. Of course, examination is very important. So we are going to discuss about how to examine hernia. I'm very specific. That's inguinal hernia, which will be always kept as a long case. Shreya, we'll go for slide. Okay, so we are going to discuss inguinal hernia in specific because that is very important, especially for undergraduate and even postgraduate. It's important. Maybe kept a short case nowadays for long case also, where we can't afford to do any mistake because it is very essential part and very common thing surgically. So in the exam, UG or PG can't make any basic mistakes in the basics, how to examine certain crucial points. So we'll discuss about that very clearly. Next slide, Shreya. So what is hernia? It's always confusing, especially for undergraduate. Hernia means to bud, to protrude in Greek, and to rupture in Latin. Definition is somebody asks hernia, define hernia. Always, especially UGs get confused. What words you will tell. It is defined as per literature, protrusion of the organ entirely or partly through its containing wall. That's a definition. Hernia can occur anywhere. Whenever there is a defect, it can occur. Here, in inguinal hernia, it is a defect in the posterior wall of the inguinal canal or through the internal ring, depending on different situations, which I am going to discuss. So, protrusion of the organ entirely or partly through its containing wall. That is the definition of gross definition of hernia as such. This is a point which you have to always remember. Next. Actually, hernia is a defect or sac. Word meaning hernia, but word meaning, but it's a defect and sac together is called as hernia. But content protrusion occurs eventually, especially in congenital hernia, especially in inguinal hernia, usually congenital, where there will be preformed sac. And the sac will be there many times since birth, but the content won't descend until this neck of the sac get widened. So they present as hernia at later period, but hernia actually will be there. Presentation will be later period because content has to descend into the sac to clinically present as or to cause any problem. So that's exactly hernia means. Next, the groin. This very commonly will say that is a groin swelling. Many times we ask students, they don't know what is groin. They get confused. They tell inguinal scrotal region is groin, and right fossa and or iliac fossa and scrotal region is groin, both sides. So it is not so. It is a inguinofemoral region. Grossly, it is called as groin. Usually, it is identified as the patient or individual to flex his hip over the abdomen, and that will oppose each other. So opposing part is identified anatomically as a surface marking for the groin. Otherwise, definition wise, it is an inguinofemoral area, not inguinoscrotal area. Don't get confused, students. Inguinal hernia is the commonest abdominal hernia. Remember, abdominal hernia, commonest hernia is inguinal hernia. It again maybe asked as a MCQ question, so don't get confused. Remember it. Next, so indirect hernia is a congenital one. I already told. That's why we say always what is indirect hernia? It is hernia through a preformed sac. That's the point you have to always remember. The word preformed sac. And somebody asks, especially in the exam, we should be able to tell why indirect hernia occurs. Or it occurs in a preformed sac. Already during developmental period, peritoneal part descend downward across the inguinal canal by the pull of gubernaculum, whatever it is, and sac will be there. And but content descent later, maybe second decade, third decade, fourth decade, because of the different precipitating factors like cough, smoking, wall weakness, BPH, or staining of anything in the abdominal wall, constipation, urinary staining. So all those things, or heavy lift weighting during exercise, although whatever the way. So then hernia content may descend, either momentum or intestine, when cause hernia. Whereas direct hernia is always acquired because of all these causes, same causes, where weakens the posterior wall of the inguinal canal, where from the through the posterior of the inguinal canal, sac protrudes outside, protrudes forwards, or a defect content protrudes forwards, causing the direct hernia. So direct is acquired, indirect is congenital one. Direct is commonly bilateral, indirect is unilateral present with, but many times eventually it becomes bilateral. So that's the point you have to remember. Direct is always acquired. Next, so both can be unilateral or bilateral, but direct is commonly bilateral. Indirect, when present initial phase is at least unilateral, but eventually opposite side also can have a preformed sac, congenital one, which we are not won't be knowing, but may present later. But through laparoscopy, when you do a tap, will be able to identify, even though other side hernia clinically it is not there, but the defect may be there, will be able to identify very clearly, even though individual presents as a unilateral hernia. Next, Shreya. So, what causes hernia? Two factors causes hernia. One is weakness of the wall. I said already, it is a protrusion through a contained wall. So, weakness of the wall is important, and to push through this, intraabdominal pressure should raise. So, two factors are very important, which you have to remember. You should be able to give an answer. Weakness of the wall and raised intraabdominal pressure. So these are the two factors which causes the hernia. So many, why this weakness occurs? Why there is raised intraabdominal pressure? Then comes collagen, collagen weakening of the collagen synthesis. Then chronic cough, ascites, muscle wasting. Then asthma, tuberculosis, previous tuberculosis. Then smoking, obesity, then staining, urinary problem, constipation, so many causes for constipation. So everything will come under why these two things happens, why these factors happens because of these etiologies. So etiologies cause of these things, and these cause of the allow the content to descend down, then cause of hernia. So this is exactly you can imagine how why it happens. So next slide. So history, this is the basic thing I wanted to know in previous slide. So unless I say what is basic thing, you can't, I can't straight away go for that. So cross idea you should have indirect, direct, groin meaning. So then of course I can go ahead with that. So history taking is very very important in hernia. Of course, generally usually name, age, sex, occupation. Occupation is very important. Straining work, heavy laborers. Again, hernia do can occur. And chief complaints, again always put the heading chief complaint in the exam when you write a case sheet. Go to the next line. Swelling, which side? Right side swelling, duration of 1 year. Then pain since 2 months. Then pain is increasing. Again, duration increasing in the size, progression, aggravating factor. That comes on the history of present illness later period, of course. So pain, why it occurs also, you have to remember. Pain is either due to adhesions, either due to dragging of the momentum, or dragging of the mesentery, or due to inflammation, or due to obstruction, or eventually, of course, strangulation. So all these things may cause pain. So type of the pain is very important when you discuss. So these are the two important chief complaint where they come. Either pain, swelling, many times it is painless, but vague pain, discomfort they will have. Discomfort is quite common. When you stand, something comes down. So they will have some difficulty. They may have to push the content back inside. So that discomfort is quite common in this patient. So these two chief complaints always you have to remember. Next. So I put it in a table so that history of present illness, past family and personal histories. So most important present illness, swelling already told, duration, mode of onset. Sometimes they say suddenly started. So that is because of some training, weightlifting, those who are going to gym, exercise, suddenly there is weakening, content protrudes out the outside one day until the sac may be there, especially indirect sac, suddenly it protrudes outside forward. Site of first appearance swelling, if it is a uh, lateral part of the inguinal canal, then it is probably indirect. Middle part of the inguinal canal, we think of direct. First by history and extent and progress. Gradually descends, comes up, comes down, and goes across the external ring and to the scrotum. So if swelling eventually goes progresses into the scrotum, then commonly we think it's indirect hernia. It is not that direct hernia will not descend into scrotum. Do can once weakening so much occurs. So we have seen many direct hernia descending down into the scrotum. But commonly it is the indirect sac because it is the natural course of the cord as such. So why it descends, how exactly it descends, that's also important. Change in the size and extent of the swelling. Reducibility is very, very important. Reducibility is very important. Whether it's not eliciting your clinical examination eliciting is different. It's history wise they'll say usually walking it increases, evening it is more, then coughing it comes out. But while lying down, it get reduced. Sometimes the patient says, "I'll have to push the swelling down into the back to the cavity, and then it will get reduced." Here, one point I want to discuss that is discussed probably in examination: reducibility and compressibility. Compressibility; these 2 points are different. That I will discuss later. But sound, they'll say gargling, some content going inside. That also they'll tell if you ask leading question. That means you will have the idea, probably intestine is the content. So these are the things about swelling here to ask. Pain, of course, it's a type of pain, vague pain, discomfort, dragging pain, pricking pain, and severe colicky pain. Once obstruction occurs, colicky pain they will have. Continuous pain occurs when there is irreducibility. Then severe pain with, of course, distension of the abdomen, vomiting, features of toxicity, along with the pain, fever, other features. Then it probably content is either momentum or intestine. Both can go for a strangulation. So severity of the pain is important. Pain where it started and how far it is going proximally. So features of obstruction also comes under that. You have to remember that aggravating and relieving factors. Cough will aggravate, then straining will aggravate the aggravate swelling and pain both. Lying down will reduce. So these factors you should ask clearly. Then history suggestive of complication. All of you know that complications of hernia are first irreducibility, then may get obstructed, luminal obstruction, then strangulation. Sometimes inflammation occurs. So these are the different complications of hernia, which we are always worried. In due course of time, it may becomes emergency, not immediate effect. Anytime it can become. So these complications, history you should ask whether he had sudden onset of pain, whether he has got a fever, whether he got a pain abdomen, distension, vomiting, constipation, recent onset constipation on spine after that means there is obstruction. So all these histories you should ask very clearly. Then give the idea. Probably it is an emergency. You have to intervene surgically immediately. Of course, initial resuscitation and initial rapid assessment. So surgery is immediately once is obstruction or strangulation. Early surgery is most crucial and important. You can't wait. So that's why this history is very important. So detailed history of present illness is important in hernia. Remember, especially swelling, pain, aggravating factors, history suggestive of complication, and past history of surgery of hernia is very important. Might be recurrent hernia, past history of appendectomy. So right side direct inguinal hernia many times occurs after open appendectomy, not laparoscopic, after open appendectomy. You know that McBurney's incision you will put sometimes difficult appendage, then you will extend your incision as a upward and outward. That is called upward laterally. That is called Rutherford Morrison incision, where you cut the muscle. When you cut the muscle, many times you may injure the ilioleucosal nerve. So once you cut the ilioleucosal nerve, posterior wall get weakened. So eventually they present as a right side direct inguinal hernia. So that may be a causative agent. Similar other surgeries, similarly, like ureterolithotomy surgeries, open ureterolithotomy, sympathectomy surgery, or any extra surgeries with the approach to the extraperitoneum in the lower abdomen, oblique incisions for any condition surgically, depending on the surgeon's choice, that may injure and eventually may cause direct hernia, right side or left side. These surgeries can be done both sides. So left side also direct hernia can occur if such incisions are made for these specific surgeries. Asthma is a history important. Spinal disease can weaken the muscular component and cause hernia. Leprosy can cause, of course, history of earlier hernia surgery. All this detailed history, part history you should ask. Family history, mainly hernia may not run in the family. Of course, sometimes congenital hernias, but commonly it is not. So, but the important thing is family backup. We should know how many children patient is having, how many siblings patient is having, and uh, parents how. So that socio-economic backup we can have. So at least three level. I'm always telling to all my students that when you ask family history, at least a three generation family history detail you should ask. Uh, patient siblings, patient children, and patient's parents. At least three level family tree is very important in all long cases. Don't forget. You just write nothing significant in the front. There is something. Everybody's family is significant. Remember, there's nothing significant in the family. So when you write a case sheet, always write so many. Just a few seconds. It is enough to ask and find out. This is the one. I got three brothers, and I got two children. My parents are doing like this. Parents, if they are not there, or what exactly happened to them. Just a few say they also feel comfortable that you are interested about the family backup. They will narrate very clearly. So that will give a family backup of exactly their family existing pattern. So that's important in all patients, all long cases, three generation family history, little detail is very important. It's not no history of malignancy, no history of hernia in the family. It is not that. They may be having hernia, mention that. It may be relevant in this case. But along with that, family tree also important. You add on to few words about that. Don't forget in every long case you should do that. Undergraduate, of course, postgraduate also. Personal history, smoking, is very important precipitating cause for hernia. Pan chewing, alcohol intake, also important. History relevant to precipitating factors. I already told respiratory, tuberculosis, asthma, bronchitis, then gastrointestinal surgeries, track diseases, constipation, mainly habitual constipation, straining, uh, previous surgery, perineal surgeries like hemorrhoidectomy, fissure surgery, or fistulectomy may cause straining. Urinary symptoms, prostate, stricture urethra, straining of the urine, old age. All this increases the intra-abdominal pressure and allow weakens the inguinal canal posterior wall, allow the content to descend down. A loss of weight, reduced weight, as if for completion hernia per se may not cause, but when there is obstruction and strangulation may be relevant. So this is the basic history. You have to always like in this order you have to write, and pointing these things are very important. Next slide, Shreya. So general examination I mentioned in that previous slide. I'm not going to detail general examination. Of course, standard thing you know. So examination should be done first in standing position, later in lying down position. This is very important. So I put in a bold letter in hydrocele, in hernia. You have to always do examination in standing position. Another area you have to do use this principle is in varicose vein. So hernia, hydrocele, hydrocele rule out hernia. Then to do some tests, and varicose vein also examination standing is very crucial. Of course, along with that, lying down also important. In the three areas, inguinal swelling, inguinoscotal swelling, in varicose vein diseases, examination in standing is very crucial. If you don't do that, if you don't write this word in your case sheet when you start the examination, that will become incomplete. It will not be accepted in the exam. That's why I put in the bold letters. Very important. Now, both side examination important. Inguinoscotal area should be examined both side. Always you would do either inspection, palpation, whatever it is. So on inspection, exact site and extent, So what is the site and extent? What is the size and shape? Site is usually in the inguinal canal. It may extend down across the superficial inguinal ring. So usually size you have to approximately say in the inspection, maybe 5 into 3 centimeter size. Then shape is usually that pyriform shape in indirect sac, globular shape in the direct sac. All this very crucial, very important clinical words there. So indirect sac, pyriform shape. Direct sac is globular shape. The shapes are very clear, very specific. So we should mention like that. And extends how far? Up to the superficial lingual ring it extends, or extends across the ring up to the in the across root towards the root of the scrotum, or extends across, comes down up to the bottom of the scrotum. So if it comes down up to the bottom of the scrotum, it is called complete hernia, inguinal hernia. Up to the across the root of the scrotum, across the superficial lingual ring into the root of the scrotum, it becomes funicular type of inguinal hernia. Only to if the inguinal canal not coming out of the superficial lingual ring, it is called as bibinocil. That's why this shape extent is very important. Should be ideal, should be assessed these things in standing position. Then important thing is before surface it should come, actually expansal impulse on cuffing should come before surface. Expansal impulse most important thing. So ask the patient to cough in standing. You as a examiner clinician, you stand beside the patient, usually right side in a stool, sit or stand, and ask the patient to cough. During coughing, you can see the impulse. Now, what is expansal impulse on coughing? It is momentarily the to increase in the size of the swelling or appearance of swelling during an act of coughing or straining. So, word momentarily is very important while defining the expansal impulse on coughing. It is well seen. It is also felt. So there is a point you have to remember. So inspection you have to mention. It is a momentarily increase in our appearance of this swelling during the act of straining or coughing. Why straining? I said child or children when they cry, swelling appears. That's why they after straining or coughing. So word momentarily is very important to define it. This differs from the impulse of the other situations like vascular conditions, when like varicose will also will have impulse. Many other conditions also will have impulse. But this expansal impulse, very typical expanse, that is very typical of the hernia. That's why that word expanse is very important to mention, not just impulse on coughing. So you should know what is the meaning. It's a momentarily increase in the size of the swelling. That word momentarily also very crucial. So how surface looks like, how skin or the swelling looks like, whether there's a visible peristalsis or not, if there is visible peristalsis bowel. And second thing, that's why I put in a different color, reducibility and expansal impulse. That's the most two important thing in hernia is expansal impulse on coughing and reducibility. So reducibility is while coughing, it increases. Then once cough is stopped, it comes down little. That is called reducibility. And patient lies down, it may go inside. Yeah, the patient stand, it comes up. And while lying down, patient may go inside. And sometimes palpation, you may have to reduce, you require some manual help during palpation. Of course, that's a different thing I'll discuss later. So surrounding structures of scrotum, testis, penis, book dimensions, penis deviated or not. This side is one side swelling is there like hernia or hydrocele. Penis may deviate on the opposite side. That's what is usually not very important. What is important in hernia is whether there is phimosis or not. So see whether prepuce can be retracted or not. Phimosis may aggravate the straining, may increase the hernia as such. So these things, surrounding structure, both sides, the scrotum, we should always inspect. Inspection on the opposite side also important while inspecting the impulse on coughing. If it's sometimes many times what patient says is only right side I have got swelling. Patient is not bothered because swelling patient has not observed on the opposite side. But when you examine, you have to look for other side also. Many situation times other side also small hernia will be there. So inspection should be done both side, inguinal region, both side scrotum also, including testes or scrotum on the other side. So that you have to look at the extent, proximal extent, the lower extent in the inguinal region. All the things, everything you have to express clearly. Surface is smooth, no dilated, little dilated veins won't be there. Skin node swelling is important because if there is inflammation or obstruction or strangulation, there will be reddening. signs of inflammation will be there. On inspection, of course, palpation will be able to confirm. So everything you have to explain us for any swelling, like exam swelling, again important comes here to help. Same features of exam swelling you should apply here and inspect. Once you do that inspection, then go for palpation. These are the landmarks which always you have to remember in when you palpate the inguinal hernia. You have to usually, if patient allows, you have to, of course, oral consent will take. Usually, written consent is not taken in our clinical setup. So just inform. You can inform the patient that I'm marking it out. Anterior superior span, pubic tubercle, and inguinal ligament. You have to mark properly, and that that two important points are mid-inguinal point. That's the point between the anterior superior spine and pubic symphysis. So you have to mark pubic symphysis also. Anterior superior spine and pubic symphysis. It is the mid-inguinal point. That point is important. 1.25 centimeter above the mid-inguinal point, deep ring is located. That deep ring should be marked. Then mark the external ring also. And pubic tubercle, different way to identify it. You can run your finger from the pubic symphysis laterally until it reaches usually 1.5 to 2 centimeter. Then until it's there at the terminal point, that is called pubic tubercle. You can mark. Mm, then muscle adductor longus, when you make it taut by contracting medially, then run the finger along the tendon of the rectal longus. It ends in the pubic tubercle. Different methods to identify, but palpation from the pubic symphysis laterally will be able to feel the pubic tubercle very easily. Not a difficult thing unless the patient is obese. Obese patient sometimes will find difficult. Marking inguinal ligament from the anterior superior ligament to the pubic tubercle is not difficult thing. And of course, pubic symphysis is important again. That is because mid-inguinal point is very important here, as well as when you palpate the femoral artery pulsation, mid-inguinal point is used, not the midpoint of the inguinal ligament. Midpoint of the inguinal ligament is anterior superior iliac spine and pubic tubercle, whereas the mid-inguinal point is between the anterior superior iliac spine and pubic symphysis. So don't get confused. Always in the exam, most of the UGs get confused. Mid-inguinal point is the most important point in the hernia. It is between the anterior superior iliac spine and pubic symphysis, not pubic tubercle. That point you have to remember always. Don't forget. And location, of course, size, shape again, firiform or globular, and warmness if it is inflamed, tenderness, surface, consistency. Surface is usually smooth, and consistency is soft in if it is a bubble, granular if it is in the omentum. Reducibility is important. So ask the patient to lie down, it get reduced. Sometimes don't get reduced. Then you have to do ask the patient to get to reduce. Patient himself has got his own technique to reduce. He does some maneuver and reduce the content. If patient doesn't reduce, doesn't he won't be able to reduce the content, then you help him out by flexing the hip and knee, then adduct the thigh, then from the bottom of the scrotum, using two hands, manually you push it, put the content by lifting the scrotum towards the inguinal canal across the superficial inguinal ring. So that is called a taxis or arrangement. Word is otherwise called as word meaning is arrangement. So taxis, what is taxis is commonly asked Viva question and commonly asked oxy question. What is taxis, oxy question? So you should know what is taxis. The method of reducing the hernia content in inguinal hernia by clinician in lying down position. Patient patient is patient's hip and knee is flexed and adducted, and through the bottom of the scrotum, manually with the two hands, slowly contents are reduced across the superficial lingual canal and into the peritoneal cavity. So that is how we will reduce manually if it is not reducible on its own. So feeling of the content, gurgling or not, momentum is Dovey content consistency, and uh, granular inconsistency. Sorry, granular, not Dovey, granular inconsistency. Expansile impulse on coughing during palpation also you have to assess. Another thing important is to get about the swelling. That's important. You have to do always in standing position. Ask the patient to stand. Between the thumb and finger, you feel the root of the scrotum. Then, if you feel only cord structure, without anything, and swelling is below that. Usually, you start feeling from below upward, from the lower part of the or middle part of the scrotum. You start feeling and go up to the root of scrotum. Then you feel it. So gradually go up and feel it. Then you feel the root of the scrotum. If it is only uh, cord structure, nothing else, that means it is content. It is swelling is purely scrotal, like hydrocele, epidermal cyst, or testicular swelling, whatever it is. It's purely scrotal swelling. If you feel cord other than cord something else, not just cord, that means it is inguinal swelling. Usually it is hernia. So that's how you will differentiate. So get about the swelling is very important to do both in inguinal swelling as well as hydrocele or scrotal swelling, to differentiate whether it is inguinal swelling or purely scrotal swelling. Is it done in standing position? Allow the content to descend down if it's inguinal. Then hold the after wearing a glove, hold the root of scrotum uh, uh, below, then go upward a little bit, feeling, then feel the content, whether it's only that one or something else. So differentiate between the purely scrotal swelling like hydrocele and inguinoscrotal swelling like hernia. Now another important test is deep ring occlusion test. That's why mid-inguinal point is important between the anterior suprailiac spine and the previous symphysis. Mark it, then ask the patient to lie down, reduce the content, then apply, use your thumb over the deep ring, internal ring. Otherwise, it is a defect in the transversal fascia, and then ideally ask the patient to stand. Then, if a content with the occluded ring, if a content appears, that means it is a direct hernia. The content doesn't appear, then release the thumb, ask the patient to cough, then content appears, that means it is an indirect hernia. So deep ring occlusion test is the most important test for inguinal hernia. Other thing is Zeeman test is there. Zeeman test ideally should do before deep ring occlusion. It's not very important test. Zeeman test I have already mentioned here before to after the get of the swelling. Zeeman test is ask the patient to lie down, then for right side right hand is used, for left side left hand is used, for indirect deep ring you occlude with the index finger, for uh, and over the direct external ring you put your middle finger, then over the saphenous opening where femoral hernia occurs, you put your ring finger, index, middle, and ring finger over the external opening, over the deep ring index finger, middle finger over the external opening, and saphenous opening is the ring finger. Then ask the patient to cough. So where you get impulse, if you get at the ring finger, it is indirect. If you get over the external ring, it is direct. If you get impulse over the ring finger, then it is the femoral. But not very difficult to make it out, Zeeman test. But it's mentioned in the textbook. You should be able to do it. So remember, right side, right hand is used. Left hand is used. Now, finger invagination test is not commonly done now. In olden days, it was done where it is very painful to the patient because through the scrotum you have to put through the scrotum you have to put little finger invaginate the scrotum from below upward. Once you reach the external ring, you can feel the size of the external ring. It just holds. Sometimes you can assess the defect. That's why it is done. Two things. One is assess the defect of the external ring. Then turn your finger like this. Once you turn your finger like this, if ask the patient to cough. If impulse appears in the tip, it is indirect. If impulse appears over the pulp, it is a direct sac. So tip indirect, pulp direct sac. MCQ it may be asked. It is not commonly done test now. Remember, not very commonly done finger invagination test. So remember 5 finger. Thumb is for deep ring occlusion test. These 3 fingers for Zeeman test. Ring, middle, and index ring, middle, and ring finger, and little finger for the finger invagination test. So all 5 fingers are used to do different tests. But most important test is a deep ring occlusion test. But if you want to do all these tests, Siemens test should be done first. Then most crucial test is deep ring occlusion test. Then finger invagination test. Remember, deep ring occlusion test is initially red reduction and placing the thumb is in lying down position because you reduce the content. Then ask the patient to stand. So it is concluded always in standing position. That point also you have to remember. It is always concluded in standing position. That is a point you have to remember. Remember again, these tests are not useful when there is irreducible hernia. Now, prerequisite for all these tests, Zeeman test, deep ring occlusion test, finger reduction test, is reducibility. Irreducible swelling you cannot do. So in such a situation, you cannot tell it is very indirect hernia or direct hernia. You just tell irreducible inguinal hernia. You can't specify. Commonly, it is indirect hernia. You can say by your knowledge, but clinically, then you have to say because I have not done a deep ring occlusion test, I could not Zeeman test, so I can't clinically say whether it is indirect or direct side. So it is right or left. If suppose right side irreducible inguinal hernia. In the case sheet, you have to write Zeeman test not done because swelling is not reducible. Deep ring occlusion test not done because swelling is not reducible. Because reducibility is the prerequisite to do these tests. So write in the case sheet if it is irreducible, write not done. So you have to diagnosis. You have to write. Don't specify direct or indirect. You tell what you have to write only. It is a irreducible inguinal hernia. Why it is hernia? It comes expansile impulse on the coming cuffing. It's the only thing because it's not reducible. Then reducibility will not come into the picture. So expansile impulse on cuffing is the most crucial part to say it is hernia. It's the most important thing. So palpation of the testis, epididymis, spermatic cord. Again, you have to do. That's important. Testis is palpable or not. Opposite side, spermatic cord. All the things you have to palpate in this patient. So again, just repeat. Landmark marking is important. Bidding on the point is important. Taxis is important. Expansile impulse on the cuffing is important. Reducibility is important. To get over swelling is important. And Zeeman test, most important is deep ring occlusion test. This should be done if a content is reducible. If it is not reducible, only you cannot do this test, right? Like that. It's a point I am repeatedly telling for the UGs. You tell not written, not done, cannot be done. That's a point important you have to remember. So these highlighted points are very, very important. Always remember. So next slide, Shreya. Shreya. Okay. Opposite inguinal region, again, I already told. Bulbar urethra, peripheral skin examine. So bulbar urethra out examine is lift the scrotum in the midline. Bulbar urethra is felt. You know that in male urethra has got prostatic urethra, bulbar urethra, penile urethra, external meatus. Of course, between prostatic urethra and membranous urethra is there. Prostatic urethra, membranous urethra, bulbar urethra, penile urethra. So bulbar urethra is the one which is most important because curvature is there. So trauma is common in the bulbar urethra. Infection is very common in the bulbar urethra because some urinary stays there. So there's a stricture is common in the bulbar urethra. So for if the scrotum in the midline you can feel thickening and crescent-like depression, crescent-like feeling. So we'll say there is a stricture urethra. It may precipitate the hernia by difficulty in avoiding the urine. We'll say yes, the exam bulbar urethra is very, very important. So inguinal node examination, there is inflammation or drainage area. You have to examine as a completion. Inflammation sometimes there is hydrocele or inflammation. Definitely inguinal node will get enlarged. So horizontal group of inguinal lymph nodes has to be examined in this patient. So bulbar urethra, superficial skin, opposite inguinal region. These things are very, very important. Show the photos, of course. Next slide. So percussion is standing over the swelling is important. Auscultation standing. Remember, percussion should be done standing because otherwise content get reduced. You won't be able to appreciate whether it is enterocyl or omentocele. If it's dull, it is omentocele. If it is a resonant, it is enterocyl. Auscultation also boils down to here. You have to do in standing. So standing examination standing is very, very important in inguinal hernia. Remember, if you don't do that, your examination is incomplete or improper. Wrong it is actually. So next, abdomen examination important again. Observe for any scar, I already told. Appendectomy scar, right side, ureterolethotomy scar, or any surgeries, surgical approaches, lower abdomen may injure ileoinguinal nerve and reduce the muscle tone, may cause hernia. Malgagni bulging is very important. As the patient lie down, raise the head and elbow, and feel the abdomen, inspect the for bulging and feel the abdomen, rectus and lateral muscles. If there are bulging, then there is weakening of the lateral muscles, which may be the cause for the hernia. And such uh, no swelling, no impulse on coughing on examination. But ultrasound confirms the diagnosis. If you put a scope, you can see the defect there. Second Clipboard classification, the standard one. Type 1, 2, 3 is a different indirect type. One is just snugly finger goes. Second is one finger who goes. Third is two or more finger goes. Fourth is direct. Fifth is direct puncture defect. Sixth is recently added double hernia. There's a modification of Gilbert, of course, not recently, modification of Gilbert. That is a double hernia, Romberg hernia, dual hernia, pentalonias, and seventh is femoral. So Gilbert classification should remember, clinical classification should remember. Of course, currently standard is European Hernia Society classification. This also you have to remember. Primary or recurrent, P or R, lateral indirect, medial direct, femoral, LMF, deferred size 0, no hernia, 1, less than 1.1 finger, 2 is less than 2 centimeter, 2 finger, 3 is more than 3 centimeter, more than 2 finger, X not investigated or not assessed. So PRLMF 0, 1, 2, 3 size, deferred size, lateral, medial, indirect. It is the current classification. EHS classification. These three classifications you should remember. Other there's so many classifications which is not necessary for you remember. This is the standard one you should remember. Clinical, Gilbert, European Hernia Society classification. Next slide. So remember, next surgical anatomy, I'm going to tell that difference between indirect and indirect sac already discussed. Different enterocyl is a resonant gargling sound is there. Enterocyl is and omental is a dull granular feel and dull on percussion. Differential diagnosis for groin swelling. You can always read my book, clinical and my manual. Complications of inguinal hernia, not surgery. Inguinal hernia, irreducibility, obstruction, strangulation, incarceration. These are the five complications. Remember, ictus hernia, part of the bowel is strangulated. Sliding hernia, posterior voluntary inguinal hernial sac formed by bowel, colon, bladder, urinary bladder, and so on. Pental is a double hernia, indirect and direct both. They present as the direct hernia, but indirect hernia is a sac is missed, eventually presents as a false recurrence. Medullus hernia is a double hernia, uh, W hernia, not double, W hernia, where one center of the W get strangulated. And so examination standing, expansile impulse on coughing, reducibility, get over the swelling, deep ring occlusion test, rectal examination, systemic examination, especially respiratory system and spine, abdomen. All these are very, very important. And remember all these things when you go for clinical examination, hernia, because it's a long case. Next one. Next, so this is one wait. This is a responsible impulse on coughing standing position. Always examine standing. You can see there is a scar here. There is a hernia here. Left side hernia upwards. You can get over the swelling. It's very, very important. How exactly do that? Next one. So this is that almost become funicular, becoming complete here. This is the indirect sac. So this is the Zeeman test. I already told. Zeeman test how to do that. Ring finger, middle finger, and index finger, middle finger, and ring finger, uh, deep ring, external ring, and saphenous open. Next one. So percussion is standing for resonant or dull. Next one. So auscultation for boils and standing again. Bulbar urethra. That is how exactly you'll feel. Look at that. This is where exactly you'll look for thickening and depression. This is the see that hernia coming down, probably uh, direct hernia or maybe funicular type of indirect, like after proper deep ring, like test only be able to see. So it is complete hernia. Previous hernia scar is there, recurrence. You can see that scar is there, recurrence hernia. From big it is, and it is a femoral hernia. Another thing I want to tell is inguinal hernia is uh, above and medial to the pubic tubercle. Femoral hernia is below and lateral to the pubic tubercle. See that is a female patient, below and lateral. See the pubic tubercle, below and lateral. Inguinal hernia comes here, femoral hernia is here, below and lateral to the pubic tubercle. Above and medial to the pubic tubercle is inguinal hernia. I forgot that one put into the slide, but remember, inguinal hernia is above and medial, uh, femoral hernia is below and lateral. Inguinal hernia is above and medial, femoral hernia is below and lateral. Very typical. Okay. Next one. So remember my book, you can read Clinical Methods in Surgery. Current edition with video lectures are there through GP Publishers. So that gives detailed examination, everything it is covered with the instruments, specimens, and other things. My manual current edition gives in detail about all hernia, operative procedure, tap per tap, retention procedure, complications, whatever economic aspect, theoretical aspect, principles of hernia. In detail, it is given. My all these websites request everybody to subscribe. Daily lectures will be there from at 6 p.m. 6 to 8 minutes with the MCQs. You can go through this Instagram and YouTube. Please, I request you to subscribe. My Digino lectures were everything covered in Digino lectures, including specialty, urology, cardiothoracic surgery, and neurosurgery, A to Z, everything, including clinical examination lectures for around more than 200 hours. You can always subscribe this one through JP Publishers for a year to have entire knowledge about surgery, theory, clinical aspect, everything in detail, all theory covered, general surgery, specialty, and other surgeries, endocrine surgery, GA surgery, everything is covered, instrument, specimen, examination, everything what is needed for to learn to a learner, UG, PG, and others. It will be definitely helpful. So next one, share next one. So this is please QR code. You can subscribe my Surgery Insight website. So daily lectures you can do, put comment also. Live lectures also will come. Eventually I put MCQs. I already started putting MCQs in each lectures. You can go through the MCQ and the next day I will put the answers. So next one, Shreya. So thank you very much. Shreya, uh, go back to the QR code. QR code. Okay. So whosoever can scan the QR code and subscribe. It is free actually, and share with others. Rajat, put your comments, whatever it is. Rajat.
Yes, sir. It was a very good class, sir. We have covered hernia examination in detail. Just two, 3 points that we always, you've already mentioned, just want to tell for the students. One is always examine the opposite side also. Because a lot of times what we do, especially in MBBS, is we are focused only on one side where the patient is saying, and we forget to examine the other side. Other thing, always ask the patient very specifically for urinary complaints. Majority of the older patient, they'll come with urine complaints, and it will indicate a prostate problem, a benign prostatic hypertrophy, which is most likely the cause. And to confirm that, always also should do a PR examination and urethra examination. That is very important, because we miss these things in MBBS times. I have also missed in my time, so I know these things.
Yeah, true, true. Because if there is a prostate should be addressed by
Addressed.
TURP.
Yes, sir.
Otherwise, you have to refer to urologist and to address prostate by TURP is a transurethral resection of the prostate. Then you can do hernia, of course, same sitting currently, not a problem, but TURP should be done.
Should be. Yes, sir.
That's important.
Yes,
Uh,
and sir, just one word, that they should also read about the hernia classification, especially the new one, the European hernia system, because that may be asked for
yeah,
exam. So they should,
EHS classification.
EHS, yes, sir.
Yeah, EHS. So they should. That's why I put that. They should remember it. Exam they will ask because in our unit students last week I asked, they were not knowing at all. There's
Yes,
such
sir.
existing EHS classification. That's important. So yeah, there is a current standard EHS classification. So they should know how it's very easy actually. They should know it. That's important. I know. I know.
Yes, sir.
So mm, so just you can tell Rajat, this is a very commonest long case kept in the exam. So they
Yes, sir.
can't miss any methodology of the examination of the hernia. That will not be accepted. So very common thing. And treatment aspect I have not highlighted, but basic thing they should know treatment because it's a basically examination discussion. But investigation and the treatment, open method, Lichtenstein method, they should know in detail how to do. So ileoinguinal nerve, ileohypogastric nerve should be safeguarded. Genital branch of genitourinary nerve, genitofemoral nerve is there in the inguinal canal within the cord, whereas ileoinguinal nerve is there in the inguinal canal outside the cord. Ileohypogastric nerve above in the inguinal region, but not in the cord structures. So that point, location of the ileohypogastric, ileoinguinal nerve and genital muscle, genital should be, they should know. Cremaster muscle, little bit they should know. How to identify inguinal ligament, also they should know. Technical aspect of inguinal hernia will be asked in operative surgery. Open method, how to raise a flap, this one above upper leaf, lower leaf. Then other currently Deserda method from Indian Pune, they how to do that non mesh non prosthetic, of course natural prosthetic, of course non mesh repair method. That the business repair basic, of course only used in emergencies. That shoulders repairs, at least few newer thing, few regular thing they should know. So many procedures are there, but at least these things they should know because it's a very common entity. They just say they have to know. Tap per tap, full form, basic idea they should have. Then shoulders method they should know. Deserda technique, also business repair. For emergency in gangrene, you can't use mesh. You have to use you have to do business repair, or you can do Deserda in gangrene patient. So there are those things they should know at least. Treatment aspect, which is not I have not highlighted in detail because of the shortage of the time. But they should read about those things, treatment aspect, surgical aspect, uh, in detail about Liechtenstein and briefly about the know should know the meanings of each type. I think no, Rajat.
Yes, sir. Yes, sir. On undergraduate level, it is enough for them to know the names and to basic what it is,
Yeah,
and just the names of the laparoscopic procedure, tap and tap.
yeah, full
For
name.
postgraduate student, they should know the procedures also.
Yeah, in detail they should have the idea,
Yes.
principles of each type procedure they should know. Like shoulder principle they should know, techniques they should know. Same thing, Bezanis, of course, mesh repair, tap to tap they should know. They can't say I don't know how to have exactly principle that is technical aspect. Whereas under UG's basic full form, some idea. Only
Yes, sir.
Liechtenstein's method they should know. Correct
They
technical step by step technique. Liechtenstein method they should know for UG's. That is the point to be highlighted.
Yes, sir.
So, Shreya, any questions in the chat box? Nothing, I think. Shreya,
No, sir, there are no questions yet.
okay.
Yes, sir.
So this is about examination hernia in detail for inguinal hernia. Very, very useful to students. Eventually, if they go through, let them. I request them to put on comments about examination of inguinal hernia. So Rajat, so this is to conclude. I hope it will be this lecture will be very useful to them. Anytime they can go through it and learn how to examine inguinal hernia. I think Rajat, right? No, Rajat.
Yes, sir. Yes, sir.
So with this, we'll conclude the session. Thank you, Rajat, for joining us. I really appreciate. Thank you, Shreya, for organizing everything. Thank you, Aditya, and thanks all dear students those who have watched or watching eventually. Thank you very much. Give your comments about these things, and also put how much you understood, how much you have liked it. If you have liked it, please like it, and definitely we'll have other. We are going to have a next session on October 2nd. Examination of the peripheral vascular disease again will be kept as a long case for undergraduate and even for postgraduates. Rather little tougher than inguinal hernia. That lot of confusions are there in examination part, which we are going to discuss on October 2nd, probably Wednesday. Again, same time, 7 to 8 p.m. So, of course, students who are interested in presenting, they can put a slide of the patient, one photo, one or two photos, then they can prepare and present. You can communicate Aditya or Shreya for the communication required, whatever it is. So we'll conclude, Rajat.
Yes, sir.
So October 2nd, 7 to 8 p.m. we'll discuss examination in the arterial system or peripheral vascular disease, which is very again long case always. So thank you, Shreya. Thank you, Rajat. Thank you, Aditya. I appreciate.
Thank you, sir.
Thank you. Thank you, sir. Thank you for the good session, sir. Thank you.
Thank you.
Good day, everybody. Good night. Thank you. Thank you.